Okay, so now officially welcome everybody here, welcome participants, welcome dear contributors to our panel 7, Enhancing Ways of Knowing, which in very different regions of the world and in very different ways have an anthropological look on clinical practices, on medical practices, and also on how medicine and anthropology can complement each other in a way. And complement is actually the good word to start with, because the two contributions of today are both teamworks, one between a medical professional and an anthropologist, another one between two anthropologists that did research in different areas in Africa. So our first research team are Roberta Baer and Jason Wilson. Roberta Baer is professor at the Department of Anthropology in the College of Arts and Sciences in the University of South Florida. And Jason Wilson is a medical professional over there, but as I take it, also a graduate student from Roberta, so bringing these both disciplines together. So the field of Professor Roberta Baer is a wide one, engaging in medical anthropology, nutritional anthropology, food and culture. With this, also cultural aspects of diabetes, but also cancer and stress. He looks upon race and health disparities, minorities, immigrants, but also international development in different regions of the world. Processes of urbanization, but especially also to applied anthropology, that she actually already gained some awards for her community engagement in different communities. And Jason Wilson is an emergency medicine physician and medical anthropologist, as I said, and since January, I'm also appointed to the leadership team of the Center for Justice Research and Policy at the University of South Florida. And as I take it, you really focus on patient-centered pathways in medical practices and community responses that you have also dealt with examples of HIV, COVID-19, how does this work in the communities? And I saw a rich body of literature, and I will not list it down over here, but one book that I want to mention that will probably appear soon, will be published soon, is a cooperation of the two of you named The Patient Experience, Medical Anthropology and Education in the 21st Century, that I guess will be published soon with Lexington Press. So what I see from your abstracts and from our conversations, you will talk about an ongoing multi-part project that incorporates medical anthropological theory and methods into physician training, and also to insert medical anthropologists into the clinical spaces. So that you kind of like want to shift the clinical gaze of physicians by integrating medical anthropological theory and also methods in the education of physicians and medical professionals, but also to integrate anthropologists into the clinical practice to develop a more patient-centered approach. Yeah, and I'm very curious to listen about what exactly you're doing, how you're implementing it, and thank you for being here. The floor is yours.
Great, thank you so much. And I think I'll probably start us off and sort of cover some ground. And there are some specific things that Dr. Baer is going to talk about as well. Let me just sort of start by telling you about who we are and how this project came together. You know, as you mentioned, I'm a practicing emergency medicine physician. I had a background in anthropology prior to medical school. So I was, and this is an important point, that I was kind of primed for this. And that's how Robbie and I have approached the students we take, is at least some priming in the undergraduate level, that they might be open to some ideas around social science approaches to medicine. But, it had been a long time ago that I had done, any type of anthropology formally with education, and had gone on through my medical training, and have been practicing for post all my training and everything for about 5 or 6 years, when Robbie and I reconnected. And we reconnected sort of based on a mutual desire and frustration, I would say, that things were sort of going the same way over and over again in clinical medicine in the United States. For me in an emergency department, and so I work clinically every day. Worked last night, in a big urban emergency department. We see hundreds and hundreds of patients a day, and I sort of help run that department and think about how we design, how we're going to care for patients, but also how we're going to make sure patients have safe and good experiences through their care in the emergency department. What's happened in the United States over the last, over a decade or so, is that, at least by words, attention has been paid more to what we call the patient experience or patient satisfaction. And more attention has been paid to what type of outcomes people have with their healthcare. I know for other audiences here, European audiences, other audiences may seem like obvious stuff. But for the United States, we really had a fee-for-service, revenue-based model that still dominates, but was an unquestioned paradigm for a long time. About a decade ago, the Affordable Care Act and some ideas around what we call the triple aim really started to bring in these concepts of starting to shift from this just do more medicine, make more revenue model to a value-based purchasing model, or a model that also emphasizes the patient experiences, patient quality, and actually trying to drive some type of outcomes with the care. The problem with that is that medicine, the way physicians are trained, the way medicine kind of is structured and is put together in the United States, there was really no way to accommodate that model. And so what I started to see in my career, is that we were kind of training people in the same way, both in medical school and in residency, which in the United States is the postgraduate training you do after medical school to become your specialty. We were sort of just doing things the same way. But then as people started to practice, we were asking them to all of a sudden become sort of experts in a more overall idea of patient experience, patient satisfaction, and how patients should have better outcomes. And those better outcomes included things like structural determinants of care, or what gets called in medicine a lot, sort of generically, social medicine. We've seen a lot more emphasis over the past couple of years, 5, 6 years or so in medicine, to try to get a better understanding of what we mean by social medicine. But that is still very nascent. That is still a very early concept, and needs input and needs influence from social scientists. So, and on Robbie's side, and she'll talk about this, I think there was also, just frustration that basically people who were doing medical training looked at a very disease-based model. Going back to, Kleinman's work in the 70s, this, idea of separating or understanding both illness and disease seems to continue to come up, even though there's a lot of complexity now about the number of pressures we have to meet. And it's not just disease and illness. There seems to be a mismatch that continues for why patients present to the emergency department or into the healthcare system, and how we know to treat those patients or what we have designed for those patients. There's a mismatch there. I think Dr. Baer recognizes that through these sort of explanatory model mismatches, and really wanted to change the way physicians were trained, and looked for a long time to do that. So we came together again. I had known Robbie from my undergraduate work, and I always joke and remind her when we teach classes together that was in the mid 90s, and so that dates us both, but dates her more than me. That's always the sort of joke I make, but because I was the student, she was the full professor at the time. So, it had been years, we reconnected in 2014 or 15 or so, and we really designed this course. And this course that we designed first was kind of our first throw into really what I consider at this point to be a long-term investment with a multi-coordinated way that we're doing this to change over time the clinical gaze, to shift it from a disease-only model or a sort of revenue-attached disease-only model to really a more encompassing patient experience model that brings in some real ideas around structural violence and some things we've learned from critical medical anthropology. And so that was, I think, part of the beginning of this. And so we designed this course. And when I designed the course, part of the way I thought about it was we could really get students to take this course because, well, I was there, and I'm not trying to, make that sound, overbearing or whatever. But the point is that it's students who are in the United States who want to go to medical school really want access to physicians, and they want access to clinical spaces to do things like shadowing physicians is what they think about. And they want to do research, and they're told they don't necessarily want to do research. They're told they should do research. And, so they're looking for opportunities to be around physicians, to do shadowing and to do research. And we thought, well, we could really attract some of these students by creating a course that allows them to do all of those things in the course, but really at the end of the day, sort of starts to prime them around a patient focused lens that sees illness and other surrounding issues in the clinical experience. And so we put together this course that really first covers some just basic ideas around illness and disease, around cultural influence, what role culture plays on the patient illness experience. Then also some ideas around participant observation and field methods, and some ideas around medicine itself and what it looks like right now. And specifically, it was designed to really be a praxis course where undergraduate students were credentialed at our hospital and entered the clinical space. And I'll tell you, that was a little, I'm one of the research directors and at the hospital, and so I have all kinds of sort of weird projects going on. But to bring undergraduates right into a big level 1 busy trauma center, we weren't sure how that was going to work. But we've been doing it for 6 years, I guess now, and it's actually worked just fine. We take small groups of students, about 12 to 15 at a time, and we credential them all in our hospital, which is a ton of paperwork. And if anybody's ever credentialed at a hospital before, and we start to bring them into a clinical space pretty quickly. And in that clinical space, they are able to do physician shadowing. But most importantly, and I think probably what is most unique to this, I'm going to let Robbie talk much more about this, is really this, in a way, it's kind of a bait and switch of participant observation being kind of turned into patient shadowing. And I think that's part of the unique thing that we're really doing here, and has greatly impacted students' lives. And they tell us about this over and over again years later. I'm going to save that so Robbie can talk more about patient shadowing. And then the other part that's very novel and very rewarding and continues is to design a mixed methods research project that continues over time. So it allows the students to do research, which is what they really need to do for their resumes, CVs, and things for medical school applications. It allows us to really kind of formulate structurally what we're doing there, and give it some meaning over time. And I'll just tell you kind of briefly, I don't want to get into too much weeds yet about the way research in clinical settings works or in hospitals works, but as you know, in the U.S., there is this law called HIPAA, which is a patient privacy law, which is, makes it very difficult sometimes to do any type of research in a hospital setting, especially with large numbers of patients, or ways to do participant observation where you might be seeing lots and lots of patients. So we spent a lot of time thinking about how to do that and how to work around that. And it really moved to mostly a quality improvement approach, trying to think about how can we make the hospital space better over time by the participant observations we're doing. So just as example, in a United States emergency department, the waiting rooms can often become very crowded. We could do a whole nother session on why that is. It's much more complicated than you might imagine. It's not just because people are seeking primary care. It has a lot to do with why you might leave one bed in the hospital open for a surgery patient who pays more. But it's a whole different, whole different discussion about the neoliberal forces driving United States healthcare. But we have crowded waiting rooms, and sometimes people leave those waiting rooms before they're seen. We've learned that the waiting room is a great space to do a quality improvement project in, where we can put students into that space. They can stay in that space and see lots of patients, and they can inform us in the hospital about why people might leave without being seen. For us in the hospital, putting the hospital administrator hat on for a moment, that's very important, because when people leave a hospital in the United States without being seen, they are often sicker when they come back, but they also are a source of lost revenue. And they also show up on a publicly reportable dashboard, which grades your hospital. So people care very much about this concept of people leaving the ER without being seen. So over time, we build a quality project where we can have people hanging out in the waiting room spaces, pretty much, seeing and talking to whoever they want through that umbrella. And that's worked very well. And then we have smaller research projects that we've integrated into that last over time as well. Just some examples, we've designed a leaflet for patients based on the undergraduate's work. And that leaflet is very grounded in anthropological ideas, where we first spent a lot of time talking to patients about what were they not seeing, what was not happening in the waiting room experience or in the ER experience, and the throughput throughout the hospital stay experience, where there were questions or confusion or things that they did not understand that they needed. And so basically taking a patient's set of generated data and then turning around and using that set of data to create a product, a patient information leaflet, and then testing that same leaflet on those very patients, and then revising that, and then creating a final product. One thing I should say around this patient safety issue. So the other thing that's happened in American healthcare is that this concept of patient satisfaction, really driven by Irwin Press, who is a medical anthropologist, and created this Press Ganey survey, which is used by our Medicare, Medicaid services, CMS, and goes out to all hospitals and all patients after a hospital encounter. The scores that physicians get on those patient satisfaction surveys inform reimbursement to both the physician and the facility. So you can imagine, therefore, there's a lot of attention paid to how to improve those scores. What you look at, though, over time is that the data for improvement of those scores is not there. There's not very well-defined best practices for how to improve that. A lot of our hypothesis around this is probably because if you do the same thing over and over again, or try the same methods in the same direction over and over again, it's unlikely you're going to reach or get past some plateau. In other words, if you look at the data on patient satisfaction scores across hospitals, they tend to plateau somewhere, even with the best improvement efforts. But most of those improvement efforts really focus on physician communication with patients, but don't really focus on trying to drive at a different way to look at the patient experience. So coming back to the idea of the long game of changing the clinical gaze, and the idea of patient shadowing Robbie will talk about, is this concept of trying to shift over how we kind of at the end ad hoc put on a patient experience lens versus having a patient experience lens as a future physician. So we have this course, it's been going for 5 years. We have this long quality improvement project where we look at left without being seen numbers and try to improve those, which gives us some carte blanche access to waiting room spaces, which are great places for participant observation. We are also having these other ideas about improving patient experience and patient satisfaction by the long game, changing the clinical gaze by placing those students into patient rooms through patient shadowing and understanding that patient experience. Then we also have these research projects like the leaflet. And then the one that's going on right now, and it's continued for about 3 years, is, and for those of you who, follow United States news know this, that we have a firearm public health, problem here, an epidemic here in terms of injuries from firearms. And, Robbie and I, about 3 years ago, after another mass shooting in the United States, basically kind of looked at each other and said, we we could really do something here. We've got a population of patients we have access to in a big urban city trauma center. Perhaps we could inform some of this epidemic by talking to those people who've been shot and trying to learn more about their views on policy around firearms and try to learn more about ways we might intervene through a patient-informed way about ways that in the future we might be able to shift firearm policy to intervene and reduce traumas. And at the time, we'd only really used the students to kind of stay in safe spaces. Talk to patients who seemed nice, talk to patients in the waiting room, not go to traumas, not go to the sicker patients. But we had such good success for the first few years. And I think we were both so frustrated and wanted to contribute to the epidemic around firearms that, we said, let's just try this. And over the past few years, that's exactly what we've done. We really have students now interviewing people who've been shot, both who've been shot now when they're able to have an interview, but also people who've been shot in the past and are still coming into the emergency department or accessing the healthcare system, having lived experiences of those firearm injuries, sometimes years and years later. And that set of data we think looks very different than other data around firearms, which is sometimes quantitative in nature, which is important, but is sort of population health level. But these are experiences of people who've been injured. That work continues. So the class, we teach every year. That's the format of it. It's a semester long class. We build in this quality improvement approach in order to get people access, but really have this observation going on. We've been doing this so long now that we have a lot of our students who've gone on to medical school and they actually finished medical school now and have started their residencies. We survey them and every year, and what we're watching for is whether or not that sort of early seed stays planted and starts to grow throughout their clinical training. In other words, what's the long-term impact of that dose of patient experience training that they get over time? And does that lens continue to kind of be altered and shift as they kind of move into their medical training? And what does that look like against other people who maybe don't have those same experiences? So longitudinally, we look at that by sort of surveying a cohort, every year and following what happens with those people. I mean, we're at year 7 of cohort data now of following some of our early students into their medical training and seeing how this impact has changed how they look at their own medical training and healthcare. As that started to grow, we also realized that a lot of students wanted to do other projects with us, to stay on with us and do thesis work for their undergraduate honors thesis. And we actually launched another course eventually where students, basically a select group of those students would stay with us for another semester, and we would design mixed methods projects for them, with them, to complete an honors thesis, and that was kind of their own. So again, right into a clinical space to go into that clinical space and to complete their own project around a specific topic. Maybe it's the patient experience of somebody with sickle cell disease and a specific intervention we might try. And that's actually the pivot I want to make here as I kind of will start to wrap up my part and turn it over to Robbie, is we started to get better at understanding how some of this work will not only inform long-term patient experience and clinical, kind of that clinical lens, but also how we might be able to directly impact the clinical setting itself. Maybe not with the undergraduates who aren't really formal anthropologists, but perhaps now that we've kind of gotten comfortable in this space, kind of understand where there are some questions or some gaps, maybe we start to get other anthropologists into that space. And that's really where my work has sort of moved to as this has gone on, is thinking about how we can use medical anthropologists to really inform clinically how we, meaning emergency medicine physicians or healthcare practitioners or physicians, sort of see how we design patient care. And, the way I think about this is very direct. One of the first projects we had tried was a sickle cell disease patient project where, as a clinician, I designed a new treatment strategy for our sickle cell patients in the emergency department. And we had reached a plateau around their experience. We felt that the care that we were delivering was better. The outcomes were better, but the patient satisfaction scores were not moving. The patient experience seemed flat. So we brought in some graduate student medical anthropologists to do some interviewing and to try to figure out what was going on, and really found an answer we would not have seen otherwise. And that answer was essentially the medicines were being delivered, pain medicine was being delivered later than it would have been before. And so even though we thought it was more evidence-based and best practice, we'd actually somewhat reduced the level of care those patients were receiving. That really kind of shifted the thinking to say, well, should we bring in people who want to do more formal PhD work, more formal medical anthropology? And so I've really done that the past 3 years. So we have a PhD level graduate student working with me to, we have an opioid epidemic here as well, really working with me in the emergency department to figure out how we're going to deal with the opioid epidemic in the emergency department. We've designed specific clinical pathways around that, which, over time, what that has done is really shifted the way our physician teams respond as well to those patients, meaning by having this pathway designed for patients with opioid use disorder, physicians have now sort of been able to see a new way of treatment that they really did not even see before. And that's been very successful. And we've really tried to kind of replicate that model and scale it up into HIV, hepatitis C, opioid use disorder, expanding that firearm strategy as well. And even now having not only the PhD students, but postdoc, we have our first postdoc now as well, and some other medical anthropologists. And as you alluded to, I've even kind of formally put my toes back in the water of anthropology, and working on sort of these pathway development issues as a formal PhD. But that is the sort of focus, the main kind of story about the course. I don't want to take all the time, so I'm going to turn over to Rob, who I know wants to talk about patient shadowing and some of the theory as well. So thank you.
Okay, so we've built this up over a period of years now. We really weren't sure where we were going, but we're now starting to think about where can other people go with this. And we had a whole semester-long course for pre-med undergraduates. Then we were invited to do a 2-day workshop. Actually, it was probably about a 4-hour workshop for internal medicine residents at the hospital. And we thought, well, yeah, we've got this whole thing we do for a semester. What can we possibly do in 4 hours? These are residents. They're already burnt out. They're exhausted. What can we offer that could possibly make a change in 4 hours? So we thought about what's the real key thing that we are doing in this project. And we decided it was what we had called patient shadowing. Now, we came up with this label because everybody knows about physician shadowing. Physicians get shadowed by people who want to be docs. People who want to be docs shadow physicians. Everybody understands that in the medical universe. We decided to create the label patient shadowing following that, which is in fact anthropological participant observation. In order to get IRB and hospital permission to do this, we needed to make it a part of the quality improvement project, but we finally figured that out. The bureaucratic challenges to what we're doing are quite extensive, but with the residents, we didn't have any of that. They're already credentialed to be in the hospital. They can do whatever they want. And we decided we were going to take these residents who were burnt out from spending every waking hour in the hospital and make them spend more time there. So the first day, we did a brief session with them, maybe an hour. We had them read Kleinman. We had them read a few other things. We taught them the basics of participant observation, pure Malinowski, taught them a little bit of Hahn and the idea of provider-patient cultures and how those differ. And we told them they had to go out and hang out with a patient for 5 hours. We nearly had a rebellion on our hands. They were terrified of the idea of spending 5 hours with a patient. These are people who spend 12, 18 hours a day in a hospital setting, and they were terrified to spend 5 hours with a patient. What am I going to say? What am I supposed to do? We said, just hang out, be with the patient, talk to them if they want to talk, find out who they are, just do anything, get them blankets, go find the nurse. If the nurse isn't responding, just do whatever. They came back the following day for our second session as changed people. They said, this hospital is doing all kinds of things that are not working for the patients. The patients are woken up at all sorts of ridiculous hours at dawn for blood draws that are totally unnecessary. We ourselves have been ordering these blood draws, but they are not helping the patients get better. They are absolutely unnecessary. And they came back with this long list of things, totally patient-centered, that the hospital was doing wrong. So the second year when we did this, we actually had to build in a part of the workshop where we not only debriefed them, but worked with people from the hospital to start to develop ways to make the kinds of changes that the residents had identified. This was on the basis of 1 hour the day before, 5 hours they sat with the patient, and then an hour or two of debriefing. So essentially what we discovered was that even with people who've been pretty well indoctrinated into the medical system, just a little dose of anthropology, straight old participant observation, can really make a huge difference. This is extremely portable. It does not require the unique team that we have here of Jason and myself, and now a few of our graduate students, one in particular who knows everything about IRB and how to make it work for us as opposed to against us. But anybody who can get permission to do a workshop with anybody at any level of training to be a part of the healthcare system can teach them participant observation. We teach it to our undergraduates all the time. There's nothing magical about this. You sit there and you listen, okay? And you participate and you observe. This is just classic stuff going back to Malinowski. We have done this now with the pre-med undergraduates. We've done it twice with the internal medicine residents. We were invited back a third time with the internal medicine residents and to do it with the emergency room residents. Unfortunately, COVID got in the way. We were also invited to do this for the first year medical students. A number of our own students had gone to our local medical school associated with our university and had told the faculty there about this great experience they'd had at undergraduates and that other students needed to get that experience. So the medical school agreed to let us teach a month-long brief course, again, a scaled-down version of what we'd originally developed for medical students. That, unfortunately, was a casualty of COVID. We're hoping that by next spring we can revive that as well. But this can be integrated into training of healthcare providers. We think at any stage it will work. Okay, so we pass that along as something that anybody can sort of pick up and run with. Now, I also want to relate this back a little bit more to anthropology. Sometimes when we talk about it, it sounds like, oh, we've gone over the edge into the medical world. And we both feel very strongly that we are really doing a very classic anthropology, but a new version of applied medical anthropology. Now, we both very much identify as medical anthropologists and applied anthropologists, but we are both fairly critical of most of what we see going on, at least at the theoretical level in anthropology. Now, we've cited some sources for you that are 40 years old. We still love Kleinman's 1978 article. We love Hahn's article on the culture of biomedicine. These things are very important and we think directly applicable to the work we are doing. We also feel very much at home with the structural kinds of critiques that have been coming out of critical medical anthropology. We see those structural issues, social determinants of health, every waking minute in the emergency room. In the United States, the emergency room is where people go who don't have health insurance, and we've got plenty of those people. We are basically a fourth or fifth world country in terms of the level of care in our country for people who do not have health insurance. Many of you in Europe live in a different world, but that's where the United States is at. Anybody who does not have health insurance can be seen and must be seen in the emergency room. So that's where they all end up. So these structural kinds of critiques are also very important. However, unlike the critical medical anthropologists, we still see culture as critically important, particularly the culture that biomedical providers are indoctrinated into. Now, we've talked a little bit about how we are trying to change that culture, but it's still out there. And we also feel that every encounter between every patient and every physician is at its heart a cross-cultural encounter. So we have use for structure. We also have a tremendous use for culture beyond, ethnic kinds of differences and all that. A real key divide is the culture of the biomedical provider and the culture of the layperson, and these remain distinct. So we are actually proposing in the book we are working on as quickly as we can. Again, COVID has gotten very much in our way. A new approach to the clinically applied anthropology that was first popularized by Noel Chrisman in his book 1982. Again, we are both dating ourselves here, but he approached clinically applied anthropology in that era, but without any kind of focus on structure. And that was a real limitation of how far we could go with that. So we are proposing bits and pieces from lots of things from the past, Kleinman, Hahn, Kreisman, certain important contributions from critical medical anthropology, but we are rejecting the pieces of critical medical anthropology that say, no, anthropologists can't engage in these clinical spaces. You are becoming, handmaidens to neoliberal biomedical practice. We recognize where American medicine is at this point, and we think that there's a real important contribution that medical anthropologists can make working in those spaces with a very clear understanding of who we are working with, their motivations, and how we actually can create changes in those spaces that improve things not only for patients, but also for the healthcare providers. Healthcare providers are extremely frustrated, particularly physicians, because their training doesn't line up with the kind of patients they're seeing. This is particularly important in emergency room settings. People go into emergency room settings, they want to see accident victims, they want to see cardiac arrest, they want to see trauma. And what they get are people coming in with opioid addiction, sickle cell patients, people who are homeless, people who have no other source of care. And there's a huge mismatch there, and we are very non-subtly trying to address these issues. So I need to wind up now. We will be available for questions after the next presentation. Thank you.
Thank you so much for this really, really amazing insight into your work. I could have listened to it for hours and hours because it's really rich and interesting. Unfortunately, we don't have all the time, but afterwards we can maybe go on with the discussion. I can also stay a little bit longer afterwards if we want to discuss more. Then we move on to the next presentation in a very different context. Our next two speakers are Professor Shelley Lees and Dr. Louisa Enria. Sorry, I'm not. I don't know how to spell it right. So Professor Lees is a professor in public health at the London School of Hygiene and Tropical Medicine, and her interest is very much between the intersection of feminist anthropology, biopolitics, medical anthropology, so gender, violence, epidemic diseases are some of the keywords that I found in your rich curriculum. You have lived 25 years in Tanzania, but also did research in Sierra Leone, and with the focus on local experiences of biomedical research and epidemic response. So it kind of like resembles what we just heard about, but not in the clinic, but in the medical research area. And the same is true for Louisa, that how I see cooperates with Shelley since 2020, also with approaches from political anthropology, and also with a focus on community experiences of epidemic preparedness and response. Yeah, and there's different projects going on that you work in Sierra Leone, and what I get, I don't want to continue too much because I want to leave you the space to tell yourself, is that you're kind of like comparing your experiences and your research from Tanzania and Sierra Leone on this epidemic. So thank you for being here. The floor is yours.
Yeah, thank you so much, and thanks, Roberta and Jason, because I thought actually your presentation was brilliant, and I think we'll probably try and go through our presentation quickly enough so that we can have a broader discussion, because I think there were a lot of overlaps in very different contexts with the kind of experiences we've had working as anthropologists and clinical research. So Shelley and I are going to talk about, as you said, kind of comparing our experience of ethnographic research in two very different clinical trials in Sierra Leone and Tanzania. And I should just say this paper has actually been published, and I'll put the link to the paper in the chat. But we're kind of want to kind of frame this into some broader questions that we're thinking about at the moment about the role of anthropology in medical research. So Shelley, you can maybe start.
Yeah, thanks very much. And yeah, thanks so much for your talk. I mean, it really sort of ran, very true with our experiences of engaging with clinicians and epidemiologists in clinical trials, and the lack of attention to social distress and other issues around epidemics that people bring to clinical trials. So I'm really interested to have further discussion about this. I am a nurse by background, so I had been doing a lot of this thinking as a nurse working on in HIV ward in the UK and then in Tanzania. So I'm really absolutely fascinated by your course and your thinking. Here, what we're going to present our anthropological ethnographic research within trials to see what we can learn about participants' experiences and what that says addresses in terms of broader political understandings of epidemics and participation in biomedical research. Next slide. I don't know who's controlling the slide. Oh yeah, great, thanks. So here we're going to draw on our critical anthropological engagement with HIV and Ebola clinical trials in sub-Saharan Africa. And here we want to highlight the everyday encounters with biomedicines and how these affect the imaginaries of trial participants and their communities. In the paper that Louisa mentioned, we compared participant experiences in these trials, and we found real value in this comparative approach, which is a comparison across contexts, epidemics, and technologies. In our comparison has revealed the salience of history and politics in epidemic contexts. So my work in Tanzania from the mid-2000s for 4 years really showed the salience of history and politics in epidemic contexts. I had been working as a nurse during the emergence of the HIV epidemic, and we saw in the 1990s in Tanzania, as in other countries in sub-Saharan Africa, the effect of structural adjustment on a very fragile healthcare systems, who were now unable to cope with this burgeoning epidemic, and this growing reliance on international NGOs for HIV prevention and care. The effect of structural adjustment was unequal for women. Women's education and unemployment was seriously affected, and this laid bare for many Tanzanian women their vulnerability to HIV infection as they turned to informal work, particularly working in bars and restaurants where sexual exchange became common. So by the time the trial was set up in Tanzania, women had higher rates of HIV infection compared to men. Sierra Leone's Ebola emergency, which I think many of you will know about the 2015 to 16 epidemic in West Africa, had a different trajectory than Tanzania's HIV crisis because of a different temporality. The speed of this emergency made the unprecedented fast tracking of vaccine trials possible. But yet the emergence of the Ebola epidemic and later engagements with the trials also made visible the consequences of extractive international political economy in places, particularly in Sierra Leone, culminating in the decimation of public healthcare under structural adjustment. So I just want to, next slide. So just to give you a timeline, my anthropological engagement in the HIV trial, which was a microbicide trial, testing a gel that women inserted before sex with the hope that it would prevent the virus entering through the vaginal wall into the bloodstream. I moved to Tanzania in 2004 and was embedded in this HIV prevention trial and conducted 4 years of ethnographic research, primarily to understand women's participation in the trial and also community perceptions of the trial. But as the previous presenters have noted, is that a lot of we as medical anthropologists are turning our lens on structural issues, and so a lot of my research was focusing on the specific historical, political and economic context in Mwanza city, which was a growing city in Tanzania and continues to be a growing city. In 2015, working with the same clinical trialists that I'd worked with in Tanzania, I was invited to set up anthropological research in a new vaccine trial that was being planned in Gambia in Sierra Leone. This trial has tested the Johnson & Johnson Prime Boost vaccine. And this vaccine is still under trial conditions in places like DRC, but has been proven to have the correct immune response, and it is licensed for usage. I was really fortunate to meet Louisa, who had been doing long-term political anthropology research in Sierra Leone. And so we worked together to develop a similar approach to conducting anthropological research in the Ebovac Salone trial. And also another trial opened up testing 2 vaccines near to Gambia, a place called Mambolo. And then we have recently been working on the same Johnson & Johnson trial, but in DRC. Our anthropological research involved ethnographic observations at trial clinics and within the local community, as well as in-depth interviews and focus group discussions with participants and with people in the community. And we've amassed an extraordinary amount of data, which is contributing still to questions around epidemic preparedness and vaccine deployment for the COVID-19 epidemic. Next slide. Our ethnographic research has revealed the ways in which clinical trials situated within specific social political contexts produce identities, relations, and political imaginations. Our research, however, has contributed to ensuring effective engagement with communities, both in the setup and the running of the trial. We found through power mapping in the community that notions of power, fairness and trust are important aspects of communities' engagements with effective engagements with clinical trials. Firstly, Louisa and her team's work really explored the ways in which power is distributed in communities, and how working with not assuming a homogeneity of power reveals the importance of understanding intra-community power dynamics and thus engaging with different community groups rather than focusing on leaders. Fairness is emerged as a way to explore how local understandings of what is fair can help inform the design of volunteer recruitment strategies. And finally, trust highlights the issue of rumours and how rumours can be effectively addressed through our active dialogue rather than through an approach based on correcting or debunking misinformation. I think the slide's gone ahead, but I'm ready for this slide. So turning to our comparative ethnographies, 4 areas we're going to discuss that emerge from our comparative ethnographies. Firstly, we found that in both trials that materiality and notions of exchange were important to participants' understanding of the value of medical research and their role within it. Clinical trial procedures involve a complex exchange of blood, money, knowledge, drugs, and so on between the researchers and those participating in the research. In addition, clinical trials are productive processes which involve time, discomfort, movement, and risk. In Tanzania, the trial provided the women who participated in the trial an opportunity to access free, high-quality sexual and reproductive care and a financial reimbursement of $4 for each clinic visit. While government and sexual and reproductive health services are supposed to be free, women are often required to pay for medication. Thus, the free services provided by the trial represented a value. This value was traded off against the effort extended to attend clinical appointments and the provision by the women of blood, specimens, and information. In Sierra Leone, the Ebola trial, notions of material exchange and the social expectations imbued in them were manifested in slightly different ways. Participants spoke of blood taking in the midst of mistrust and fear as a sacrifice. This was accompanied by expectations of exchange or material recognition of this sacrifice, such as in requests for the trial to provide food after blood giving. Longer term expectations were expressed in the belief that there must be something else coming, or that the Ebovaxalone trial would provide some package of benefits or even potentially employment. And Louisa will come back to what this means at the end of the presentation. Next slide. Both trials created platforms to discuss the uncertainty of the present. Rather than center these narratives on misfortune, however, trial participants reflected on risk as possibility. Hope was imbued in the technologies themselves through narratives of protection, well-being, and expectations of individual and communal betterment that the trial's presence was seen to symbolize. Engagements for biomedicine, in other words, generating new avenues for imagining the future. Though expressed in more open-ended and uncertain terms than the biomedical triumphalism of technologies like vaccines, these anticipations were no less hopeful. In the HIV trial in Tanzania, women articulated uncertainty in everyday life and in the precarious nature of their existence. They dealt with threats and possibilities by drawing on strategies to reduce the chance of negative occurrences. I'm so sorry. There's somebody drilling next door. Can you still hear me okay? It will stop in a sec. I'm so sorry. Can you hear me if I keep talking?
Yeah, we can't hear the drill.
Oh, okay, great. Okay, that's great. So they dealt with threats and possibilities by drawing on strategies to reduce the chance of negative occurrences and to increase the possibilities of positive ones. And this included participating in the clinical trial. In discussing HIV, the women constituted themselves as actors of illicit behaviour or as powerless subjects of men's illicit behaviour. They participated in the trial to alleviate their anxiety about HIV infection. However, the uncertainty about the gel's effectiveness accentuated this anxiety. Whilst they understood that the gel's effectiveness to protect against HIV was uncertain, the gel was, however, imbued with hope. Specifically, they hoped that it would protect them from HIV through its cleansing and lubricating properties. The Ebovax alone participants also articulated uncertainty in two interrelated ways: to express concerns about the vaccine itself and to relate their experience of the trial to everyday experiences of insecurity. Drawing on experiences of uncertainty and on an acceptance of destiny, participants took part in the trial with both apprehension and hope. An acceptance of risk, in other words, also opened up the possibility that one's destiny in the trial could be positive. Hopes were linked to an expectation that the vaccine would work for those who took part in the trial, and that the possibility the vaccine would be able to cure other ills and to lead to a general improvement in their health. I will now hand over to Louisa.
Thanks, Shelley. Can we have the next slide? Thanks. So to continue with the sort of themes that we identified as being, in a sense, sort of common across our experiences of working in Tanzania and Sierra Leone, but also, I think, importantly, sort of instantiated quite differently in different places and given quite different technologies that we were dealing with. So the next theme was about sort of social relations and moral economies that both sort of become visible through participants' engagements and sort of the broader community's engagement with clinical trials, but also the kinds of relations, identities, and kind of regimes of morality that are sort of created and sort of generated through the trial itself and participation with the trial and imaginations of clinical research as well. So, for example, in Tanzania, Shelley's discussions with women who had participated in the HIV trials kind of highlighted how their women's decisions to participate and their experiences of the gel were articulated through broader discussions about concerns about sexuality and relationships with men, for example. And how kind of the role of the gel might kind of feed into these broader discussions about how to enhance intimacy and trust and how to kind of reshape gender relations. And similarly, in both trials, we sort of found that there was there was a feeling that participation in the trial and engagement with this kind of new, in some cases, especially in Sierra Leone, kind of new experiences and new encounters with biomedicine were also imparting new forms of knowledge, and that there was a sense of belonging in a process of knowledge production as well. Though, as we'll sort of mention a little bit towards the end, obviously the kind of politics of co-production in this context are more complicated and need to be interrogated, probably along the lines of what, although again in a different context as to what Jason and Roberta were talking about. In Sierra Leone, the research that I did with our team there kind of highlighted a slightly different type of social relation that was quite specific to the kind of context in which the trial was being established. I guess the important thing to imagine is that this was a large medical project that was set up very rapidly, very quickly in quite a small town in a moment of great crisis during the Ebola outbreak. And so this meant that the sort of broader town's understanding of what the Ebola vaccine trial was integrated in kind of much broader concerns about what was called at the time Ebola money. So this kind of question as to who was benefiting from crisis and the kind of political economy that goes along with the humanitarian emergency, and kind of critiques of both kind of the strangers or people who are being recruited to come to the trial from other parts of Sierra Leone or from abroad, but also really strong kind of expectations and obligations that were placed on residents, or kind of what in the north of Sierra Leone are called sons of the soil or Lasari, in terms of what the expectation that they would give back because they had been given access to this new kind of large, to some extent, sort of development opportunity as well. So that's sort of why we kind of have been thinking about this in terms of not only social relations, but also moral economy in terms of obligations and kind of the demands that are placed on individuals who are engaging with the trial. Next slide, please. Thanks. And so I think relatedly to this question of sort of social relations, obligations and demands, but sort of transported, let's say, into kind of a political discussion and the political context, We also looked at how there were very different types of political relations and identities that emerged through engagements with medical research. And in particular, how these engagements and these technologies, and these different technologies in particular, sort of created opportunities and new kinds of languages to articulate and to express what were often sort of much longer standing political struggles and kind of debates about the meaning of political community, and also about the kind of boundaries of specific political identities as well. So in both trials, we've been sort of doing research over a long period of time around rumors and anxieties, and in particular, what I think many of you will have encountered in other contexts, kind of rumors about blood stealing, for example. And I've sort of situated these in kind of broader discussions around how we can see these kinds of rumors both as an expression of very legitimate and serious anxieties and concerns about participating in medical research, but also as political critique. And so as ways of kind of articulating questions about power, questions about international interventions and the legitimacy of kind of medical research happening often from the outside, and also about sort of the role of governments and different types of sort of political actors as acting as gatekeepers of medical research, for example. But these kinds of rumors and anxieties that we've been studying have also been we've also identified how they coexist with other forms or other types of expressions of citizenship that are either specifically about, for example, in the Tanzanian trials, about taking charges of your own health or on your own protection and protecting yourself from HIV, for example, or as in the case of the Ebola vaccine trials, how they're kind of situated actually in political struggles and discussions that exceed and are beyond and much longer standing than the trial or even Ebola itself, in terms of, for example, when participants sort of compare the kind of care, the health care that they receive within the trial as ways to kind of reshape and reform demands that are made on the Sierra Leonean state as to what kind of care should be expected from them. And similarly, kind of the notions that taking the Ebola vaccine, as Shelley's already mentioned, were kind of articulated as a form of of sacrifice, but also a sign of citizenship. And so our participants, for example, will talk about the importance of doing this as a Sierra Leonean to protect the nation, but also to articulate, as I've just said, sort of specific ideas of obligation that go along with these kind of expressions of citizenship. Next slide, please. Okay, so I'll sort of try and wrap up very briefly here so that hopefully we can have a discussion with the other papers as well. So in our paper, we discuss a little bit the value of doing this kind of comparative ethnography and seeing how kind of different biomedical technologies locate themselves in specific social realities and social imageries, and how they produce specific meanings and identities. And also sort of to identify the importance of doing this kind of comparison in efforts to kind of identify both how they similarities in the ways in which, and solidarities as well, in the ways in which participants engage with biomedical technologies and medical research in particular, but also how these are enacted in quite different ways across different contexts because of different histories and different trajectories. So as Shelley's already pointed out, I think it's significant to look at how the gel, for example, in the Ebola vaccine intervened into two quite different crises that had very different temporalities. But also in medical emergencies that were actually situated in a similar trajectory, for example, of economic and social crisis in relation to structural adjustment, for example, and kind of similar trajectories of kind of global entanglements as well. And I guess for us, what's really interesting is then how these kind of biomedical technologies then situate themselves in these broader political struggles, and how they can create new or offer new repertoires for talking about political subjectivities, for example, and also about community as well. And the last couple of things we wanted to say and kind of really set it up as a question, I guess, for to discuss. And I think I think it's interesting to discuss it in conversation with what came the discussion before us. Is first of all, we've been doing a lot of thinking recently about what is the role, what should be the role for anthropology in clinical trials in particular. And I think we contend with similar critiques and concerns that Roberta and Jason talked about in terms of, what, is our role best kind of on the outside, kind of observing, or what is our position within, and how fraught is it at times to enter these clinical spaces? And what are the kind of both the ethical but also the kind of political, I think, kind of obligations that we have when we are situated in these processes. And it kind of made me think of Adia Benton's keynote a couple of days ago when she was asking the anthropology of the good for what, and I think also possibly for whom. And so I think it's quite interesting for us to be thinking about, I think we've played an interesting role, and I've learned a lot, certainly being a social scientist embedded in a clinical trial, as to how we can change to some extent, and often quite limited but important extent, kind of clinical practices. But to what extent can we also start contributing to a kind of a rethinking of the role of publics and participants in clinical research, which I think we feel that at the moment it's quite depoliticized, and it's also often only at the end point. So in terms of, the role of the anthropologist in kind of ensuring that that participants in clinical trials kind of feel, have a good experience, or that they feel that, that their kind of mistrust and concerns are kind of dealt with, which I think is really important. But I think we're starting to try and push the conversation a bit further up the chain, let's say, to kind of think about, is there a possibility for prospective medical research participants, for example, to have a role in research design, in kind of thinking about the political economy of research at global level, and more recently also in terms of, we work on vaccines, so also about questions of vaccine equity and distribution and so on. So I think I'll leave it at that, and hopefully we can have a discussion. Thanks very much.